right, testing 1 1, test 1 1.
All right.
Test 1 3, this is the Reverend. Test 1 3.
Perfect.
Test 2 3, Dr. Weber. Test 2 3, moving away from the mic. Can you hear me?
Yep.
All righty. Test 3 3, 3 3 test.
We're going to be done before time.
It is spoken.
Okay. Good afternoon, everyone. Let's go ahead and call to order our Board of Managers Annual Budget Retreat. I want to say welcome to everyone, and we'll say that we will have a closed session, so we will have information presented to us at the beginning, but we need to have a closed session so we can have some serious dialogue. So just remember that we will have closed session, okay? So moving right along, following the agenda, Dr. Duncan, you're up for overview.
Oh, thank you, Chair. Mr. Bose, thank you for allowing us the opportunity. We've done a huge amount of work here around budget time. We looked at it a little bit differently this year. I think with my new seat as CEO, I really had to start looking at what were the external impacts that were coming on to JPS just based upon having gone through COVID. So looking at it both as an essential hospital, which is who we are, and then also looking at the external factors from a national, from a state level, and then from a more local level. So I'd like to run you through kind of how I began the process of looking at what will be the work that we do, why it is that we do that work. Sharon will then talk to you of how the budget aligns with that, and all of this does align with our strategy that all of you have been a part of. I also would like to thank Chairwoman Ms. DeBose and DT for the time that they have spent with staff members in helping us come to this point today, the budget retreat. So if there's anything that you don't like, you're welcome to blame that on Ms.
Well, thank you.
I just want that out there. I always take the blame off myself. That's something I do well. Okay. So let's just run through this. First of all, I think we all know that we are a tax-supported healthcare system, and that JPS, and what I want you to take away from this is that we are very much integrated into the community. And so there's not anywhere within Tarrant County communities that we probably don't have some presence, whether it's with actual facilities, with services, or with partnerships. And so you can see here that we do a lot, and we're in a lot of places within Tarrant County. Just want to remind us of our mission, vision, and values. And, I went back and looked at the history of JPS, of John Peter Smith himself, who in 1877 deeded some property to take care of, and I want to quote this correctly, I'm going to get my glasses here, but he said that he wants to provide care and provide the best medical care regardless of race, creed, or origin. So that's really who we are and who we have remained. And I thought it was interesting that he always talked about the best care, and it really aligns with our moving towards excellence in all of the care. So our mission and vision and values have held true since the days of John Peter Smith. A little fact about him, he actually brought the railroad system here to Fort Worth, so when I always have to stop at railroad tracks on my way home or throughout Tarrant County, I can blame John Peter Smith for that. Again, our strategic plan, and I did circle here, was to sustain financial strength, and that's what we'll talk about today. Bill actually found this slide. I don't know if we realize how much regulation goes on around hospitals. And I think this really, what we have to do from a regulatory standpoint, what hospitals have to do from a regulatory standpoint, whether it's at the federal level, whether it's at the state, and then JPS themselves being overseen by the county even has another complexity to it. So I want to talk a little bit about essential hospitals. We, in fact, tried to get Bruce Siegel, who's over American Essential Hospitals, to come speak to the board. He was busy, and hopefully we may be able to get him next year. But I just want to remind us that JPS is an essential hospital. And that means that we care for people who face financial and social barriers to care, that we have some national and regional referral centers around our trauma, our burn, our emergency, psych, our NICU, that we do have primary and specialty care, but more importantly, that we are located in our communities of needs, that our patients have higher acuity, that we provide the majority of the uncompensated care, that we are large, that we're committed to teaching, and that we have very thin margins. So I think as we begin to look at just how we become financially sustainable, we've got to remember kind of where we are as an essential hospital. This next one, I just want to again speak about where essential hospitals are located. I thought what was interesting about this one was that if you look out on the East Coast, there seems to be a lot more of the safety net or the essential hospital where they are located more on the east side, and then as you move more to the west until you get to California, there's very little. And I say this because we struggle sometimes as to just how we begin to message within our community our importance. Whereas when you're out on the East Coast and having come from Atlanta and even Chicago, there is this real support for the safety net hospital because they know how important these hospitals are within their community and the large role that they play. Also, being an essential hospital, we do have special populations of individuals that have challenges of their own, those who are experiencing homelessness, also those who often are below the poverty line. And then I thought this is somewhat interesting around the number of our community that are experiencing food insecurity. And this has been a big topic. Even here in Fort Worth, 1 out of 4 residents actually are considered to not have access to healthy foods. Again, just to remind you, I think we all talk about our case mix index, and we do have higher patient acuity compared to other non-essential hospitals, and we do have the bulk of the uncompensated care. We are large. We see more patients both on the inpatient and on the outpatient side and with ED visits. And we train and teach, do more teaching than our non-essential hospitals. On average, your teaching hospitals train about 240 physicians, and I thought it was just an interesting fact that we here at JPS train 227, so more than what the national average is. So a real commitment to teaching. Again, we do operate within margins compared to the overall hospitals. So let's look at the federal and national levels. As we know, about 27% of the federal budget is in healthcare. And over the next 10 years, this will grow and surpass $1 trillion. So this is not sustainable. COVID impacted where we're at today. We continue to be up and down with these surges as to what kind of funding, additional funding that we receive. We have, as a result, started to see and to have to address a lot of the staffing shortages that came out of COVID. Supply chain. We know that COVID created a supply chain problem, and there will continue to be increased cost. on staffing and based upon our interruptions in supply chain. And then some of the headwinds that we'll face is that these additional reimbursements that we received as a part of COVID will start to go away. We don't see that the cost of goods and staff will come back very quickly to pre-COVID levels, and that our volumes will continue to be unpredictable. And so in our attempts to set volumes with our budget, we really are a moving target. So just want you to understand that as Sharon starts speaking about how those volumes were set. Workforce and labor, and you hear us talk a lot about it. But as you see on the right side here, and up on the top right side, hospitals, when they are looking at what their number one concerns and priorities will be for this next year, number one is the workforce. Number two is the workforce. And number three is the workforce. Now, I'm going to give you guys a different number two and number three, but we are probably not going to be able to really be highly effective in number two and number three that we'll be working on unless we are able to get through the different challenges that the workforce and labor is now presenting to us. I won't go through here why it is that we are seeing these challenges in workforce. We do see that in the hospital, in our inpatient areas, that it's going to be a little bit more difficult than it is in our ambulatory settings. A lot of this has to do is that your ambulatory settings tend to have more of an 8 to 5 work schedule as opposed to your inpatient, which tends to be more 24/7. Again, I will not go through this. I do want to highlight that these last two bullets here, that 55% of our RNs are new to organizations over this last 3 years. That's a huge turnover, and we talked a little bit about that yesterday. And that 42% of RNs are looking to move away from the bedside. So again, some more headwinds that we'll be facing. 18% are projected to leave nursing. And just to give you some perspective on what's gone on here at JPS, we have replaced over 50% of our workforce over the last 2 years. Over 50 is somewhere around, it's closer to this 55%. And although the majority of our workforce are, nursing, that is the struggle that we have.
Karen, that's a first for us, because usually our nursing staff had longer tenure. Mm-hmm. And so that's a major change for nursing.
It really is. And, you've got that huge turnover, and I think a lot of it was that many of them left and went to contract and agency where they could get higher rates, especially as COVID was moving across the nation. We were slow to return a lot of that. I think a lot of them began to rethink their lives. But the fact that you've got that huge turnover and you still have 42% of your nurses who are looking to leave nursing, mm-hmm. I think it's going to be a dance. It's going to be a difficult one.
Is there an age breakdown, or is it just a cross nursing period, whether it's a nurse that's been in the industry longer or a new nurse, or is it just across the board?
I don't know if I have Jill behind me here. I would say it's probably across the board. You did see a lot of nurses who were ready for retirement. Nurses tend to stay even a little bit longer than, what's traditional retirement age, and Dorothy can speak a lot to this. But there were a lot that just decided to go ahead and retire if they were close enough to retirement. Okay. And so, and part of our strategy moving forward will be how can we bring them back to the bedside, especially, or use them for their just historical knowledge, for their experience that they have in training some of our new nurses. And so looking at them in a different way.
Several young ladies, I think about 12 or 13, who are nurses in the church. and all of them, I think all but 2 have stopped nursing, well, still nursing, but gone to be the traveling nurse. They said it keeps you from being so attached now, and the dollars are greater.
Yeah.
So many of them are leaving the hospital setting and going to just, you sign here 6 months, whatever, and then you go to another spot. And
Yeah. And some of those nurses that originally, I mean, they were making huge amounts, and they were able to travel places they hadn't been able to
Yeah.
travel. And some of them came back and had really made as much as they had made the year before within a very short period of time, and decided, let me stay home with my children, let me do something a little different. So COVID just really kind of tipped a lot of kind of what we're seeing, or contributed to a lot of what we're seeing. As far as volumes, and again, Sharon will speak to this, that, we, during COVID, did not, a lot of our ED volume was down, a lot of our volume in our ambulatory setting, of course, many of ours were closed, but a lot of that was down. And in 2021, as we started to come out of COVID, we started to see some return of that volume. Still not to real pre-COVID levels. We have seen our hospital-based surgeries, or what we call our inpatient surgeries, or those surgeries that are done at the hospital, have remained below pre-pandemic levels, and we talked a little bit about that yesterday as to why. But we're seeing this across the nation, while we see more pickup in our outpatient surgery centers. And so what we are seeing here is what's being seen across the nation. And I think there's still a lot of teasing out with that. And then the complexity of patients that we are starting to see. And, for our patients, we've always had a very complexity to our patients. The fact that they were not able to get in during COVID really created probably some additional complexity, and so there's a lot of pent-up demand, and the patients are much sicker than they had been. I won't go through this, but we have seen cost in labor. Across the nation, we see cost in labor up 19%, supply chain up 21%, prescription drugs up 37%. So with all of these expenses, it makes it a little bit more difficult as far as our margins are concerned. I thought this was a little bit interesting. I mean, I've always talked about taking care closer to our communities, or taking it closer into the home. And there's been this real push of hospital to home care. We're starting to hear a lot about that. And there does seem to be probably some validity to that we will start to see some of what we traditionally have cared for in the hospital start to shift out into more closer to the community, into outpatient setting. This will affect our revenue depending on how the costs are set up, or how you're incentivized, and as far as payment is concerned. And so this could, as we shift to outpatient, could affect our overall revenue. And if we think about it for our patients as hospital care, if we talk about moving hospital care into the homes of our patients, who this may be actually somewhat difficult because many of them don't have the setups within their home, getting caregivers out into many of our neighborhoods becomes more challenging the more spread out that we are. Having lack of broadband across all areas will make this a little bit difficult for the patients that we care for. So it may not be as easy for us as we think it is. Of course, there will be some payer mix changes because we are starting to see a lot of baby boomers starting to move into Medicare. If you can look at the third bullet up, 2 million baby boomers will become eligible for Medicare each year until 2029, and there will be about 71.3 million baby boomers who will be Medicare eligible. So the percentage of insured population will come from governmental funding sources. I'm going to pass over this one. A lot of policies will start to see changed. Some of the policies that were set up for COVID will start to come down. We continue to work under the emergency plan in order to provide care spaces here in the hospital. So we will see some of that start to change. The Biden administration, I'm sure all of us have heard some of the ways in which he wants to change healthcare priorities and looking at prescription costs most recently, and being able to keep more people on the Affordable Care Act through the holding of premiums. All of that will start to affect the shifts of our patients. Behavioral health demand, I think we will be in good position for, but there will be a lot of this moving forward, and we see this at the federal and national levels. And this will be both on adult and pediatric. So let's move to the state and what's going on at the state and where we think that we'll be impacted. The bottom line is that there will be probably little impact to 2023 for us as to what's going on at the state, and I've had some conversation with our state government relations people. There will be some monies that will help us better fund some of our behavioral health beds and needs, and there will be some expansion of GME. We do not feel that there's going to be much change than what we see. As far as supplemental funding, and Sharon will get into this a little bit, we will see some increase in our uncompensated care with some reduction in our DISH. All of us do know that DSRIP has ended, with the last payment having been this year. And then as far as CHIRP and TIPS, they'll probably offset each other. Let's head locally. We will continue to grow. And that growth will be largely in those of individuals of color, and we know that population does have more chronic disease, and so that will have an increase. We'll see a lot of increased need in care and cost of care as that population starts to grow here in Tarrant County. The growth in age groups will be between 30 and 44 and between 65 and 84. So again, we'll see a large Medicare, part of that Medicare growth we see nationally will also occur here. And then as far as our court and our board will change. And whether we'll see it, we will see some of that next year. But I would say probably over the next 2 or 3 years, all of us, this will look a little different here. So we'll have a new judge and 2 new county commissioners with the potential for a change out of some of the board members. and there will be a new level 1 trauma center that will be opening at the end of this year. I think I'll be honest with you, I really don't know. And we've had some internal conversation, although there doesn't seem to be a lot of anxiety here. I think the fact that we have been here for some time and have really great trauma care that goes on here, I think it will take some time for the new level 1 trauma to come up to speed. My concern, Steve, will be that there will not be a big pool of at the provider level here in Tarrant County that we could really be having to compete a little bit with. From a staffing level. And I think it'll probably be more that than it will be, will our numbers, actually go down. Tarrant County is growing, and THR is a level 2 trauma, so they are receiving a lot of this, a lot of the trauma for Tarrant County also. So I don't really know what this is going to mean. Bill, you have any thoughts on it? I can give you some experience in Atlanta where one of the hospitals went to a level, decided to open up, I think it's your old stomping ground, isn't it, Bill? But decided to start a level 1 trauma. It is very costly. I mean, it's a lot of heavy work, and they were not successful at really being able to do it at the same resource level that the Safety Net Hospital, Grady Hospital, was able to do it. Yeah. So.
Changes that's going to take place. The material that you just shared with us, just went over with us, I was sitting here thinking would be healthy if there was some work session that maybe the commissioner's court could receive and hear this information, because I think one of the struggles and problems will be they don't really understand healthcare and how it operates. They just see county hospital, and it maybe be a political tool for them to bounce around. Now, I don't know how we could work that, but I think it would be good if we board had commissions around the table and went through something similar. Yeah. Once that election has taken place, if we could pull that off, I think it'd be helpful. Matter of fact, I think Steve would love to make the presentation.
Yeah, I was getting ready to say, let me delegate that to you and to Mr. Montgomery.
No observation, relative, especially to the workforce issues, Karen. I mean, statistically, there's fewer women in the workplace now than there has been in decades. When you start to look at that and the impact of the baby boomer retirement, the great resignation is what we call it, there's fewer people in the workforce, period. Mm-hmm. Every hospital is going to have fewer people to pick from. So especially when you look at nursing and the percentage of our nursing population that's female, if we start looking at what it takes to attract that group to JPS, should we be thinking about offering childcare?
Oh gosh, I probably have a bunch of nurses now who are cheering you on.
It's the number one issue.
Yes, it is.
I'm serious. Serious. I mean, it's spot on. We got to do something.
Trent takes the first shift.
And we can.
I'm used to it.
We'll have some of those discussions in close, because I think that those are some of the things that we would have to feel comfortable with. I mean, it's not easy. Again, you saw the regulatory bodies that oversee us, and for for us to jump in and become a daycare center may not be the best way, but we may be able to provide daycare or to help supplement some of the daycare costs and other partnerships that,
I think everything's got to be on the table.
yeah, exactly.
Okay.
Okay, we're going to finish by just looking at JPS. So taking into account who we are as an essential hospital and all that's going on exterior to JPS, and just kind of what will 2023 look like. So workforce will continue to be a challenge. There will be intense competition in the Dallas-Fort Worth area because, as Trent just said, we'll be all sharing the same individuals. We're looking at the same individuals and trying to recruit them. Our hardest to fill areas right now, and we do anticipate this will continue, will be the emergency department, critical care, perioperative, women's health, behavioral health, all not good areas. It takes a lot of training in those areas. Hard to recruit to begin with pre-COVID. Just to put some perspective around this, since between January and July of this year, we've done a lot of hiring. Over 1,200 employees have been hired to JPS. Over that same period, we lost 961 employees. Yeah. So recruitment, we see, will remain a challenge, and we will not be able to recruit our way out of this. We will have to try our hardest to retain, and it's not always the dollar. So some of what Trent spoke about. I'm looking at other ways. We see that we will remain mission-focused, and we will remain committed to teaching and training, so we don't see any change with that. We see that we will continue to see an increase in the demand for care, especially around behavioral health, and that there will continue to be a high patient acuity. Again, those patients that waited to come in will now come in much sicker, and that we will have increased number of patients that are sicker within our current facility constraints and limitations. So the importance of really what the bond will allow us to be able to do and being able to handle what's coming in. But we will struggle next year because of the limitations of our facilities. We do see that we will continue to see a shift of care from, especially as regards to surgery, from inpatient to outpatient. That there will continue to be uncertainty around supplemental funding, that we will continue to have high uncompensated care, and that our margins will continue to be thin. So our priorities, what we see to be the main focus for next year, will be workforce, ensuring that our master facility plan is realized, and that we look at ways of caring for our patients as it pertains to access, as it pertains to how we will begin to manage our patients, especially our JPS connection and other populations that we see. And so you will see as Sharon begins to outline kind of the assumptions that we made, how it is that we are laying out our budget for next year that takes into account these areas of focus. That said, I'm going to turn it over to Sharon.
Did anyone have any questions of Dr. Duncan before we move to Carol?
And
Okay.
we'll talk about some of this and close
All right.
as to whether these are the
Okay.
right priorities.
All right. Okay, Cheryl.
So as I work through this, just a reminder, we have what we feel like is a draft budget. We will be working to kind of package all of this for approval on August 11th at our scheduled board meeting. So here is kind of where we're planning around those three major areas that Dr. Duncan just recognized. On the workforce, although we're still working through the details of this, we have earmarked about $7.5 million for the new physician comp plan redesign. We also, for several years, have been talking about a living wage. Last year, we were able to raise that to $15 an hour. So at a minimum, our lowest paid employees would not be lower than 15. We also have earmarked some dollars to raise that to 17. That was kind of a 2-year plan that we rolled out last year. We've also included our annual merit increases for the staff that are here. And as Dr. Duncan mentioned, a continued focus on both retention and recruitment. Around the master facility plan, which is top of mind for everyone, the bond issue is actually coming to fruition. I expect that during the first calendar quarter, we'll be going to market for no more than $389 million worth of debt. Currently, tax-exempt debt is at around 4.85%. That would roll out to both interest expense and bond issue costs that we would need to account for in '23. Our foundation, with new leadership, we are going to embark on a feasibility campaign to raise capital. We've included dollars for that, as well as some of our phase 1 projects, especially around the temporary parking as we set up to kick off other projects. We'll start to create expenses in this current year in '23. And of course, our patients, we do have initiatives around length of stay. If you remember yesterday, we kind of looked to see that our length of stay has decreased over the last few months. So we have, that will increase our bed availability, as well as reduce avoidable inpatient days, help with the throughput discussion that we had yesterday as well. We're also planning a gap analysis and to start redesign of patient management around our connection patients. This will be a journey. The assessment itself is estimated to be about 9 months. And then once we do the gap analysis and get a plan around that, based on the experts that I've been having discussions with, that redesign would take another 18 months. But we do have dollars in there to begin that. And then, of course, our medical home Southwest will be begin construction in '23 as well.
Sure.
Yes.
First quarter of the calendar year.
Yes.
Just roughly, how long does it take to sell those kind of bonds? I mean, you issue them, how long is it in the market before we?
So we will start to plan that, and it takes anywhere from 4 to 5 months from the time you vote that we are going to issue bonds as a board to when they actually fund. Now, we have a reimbursement resolution in place that the board approved a few months ago, which allows me to spend my operating cash, and when we do get that cash, I can reimburse myself.
Okay.
For those. So the bonds themselves are not a milestone that you have to have before you can begin construction.
Okay.
But in order for me to bring that to you as a board for approval, we still have some work around timing, cash flow, and definition of those phase 1 projects.
Right. And the debt service begins as soon as they start selling? I mean.
Yeah, actually, the bonds will go to market on a day, and if they don't sell that day, our underwriters will typically buy them for
Roger's in
resale
half.
later.
Roger's in for half of the first.
That's what I've been told,
Yeah.
yes. So,
Good.
but yeah, if you remember discussions with First Southwest, they've recommended co-underwriters, and then we have 3 or 4 others that will also assist with that $389 million. So there's not much risk that the day they go to market, we will not receive full funding
Okay.
of that.
Okay.
But to Steve's question, Sharon, when it comes to when we start paying for bonds, you're going to capitalize interest for 18 to 24 months, right?
So from a bond issue cost, we can no longer, I have to double check on this, Roger, but some of the rules have changed on what we can capitalize during the construction period. So the interest expense that we are planning to pay the first year is going to be a $14 million expense.
Okay.
The interest capitalization rules are different.
Well,
So-
I know, well, I live in that space every day.
Yes.
You can still capitalize interest. The time period that you have to be able to spend the first tranche of bonds has changed, but you're not precluded from capitalizing interest. And that would push you out from having to make your first bond payments 18 to 24 months from sale. So I don't think you start paying for them immediately.
Okay, well,
There'll be some time between the time you issue and the time that you actually start paying for them.
okay, we'll go back and have some more discussions there. But we would expect to go to market January, February of next year.
I have a question, Sharon, on what are we hoping to achieve with this connection patient management gap analysis and assessment? What's the outcome? What are we looking to achieve with that?
Yeah, so last year, we had a lot of conversation around this, and we thought we were going to move forward with having a VP over our health plans, our JPS connection. We quickly found out that we do not have the infrastructure in place, and that to start to look at JPS connection as a health plan was probably about a 5-year lift. And so we stepped back off of that and decided that what we would do is to begin to work with a consultant to help us begin to map out how we might look at managing the JPS connection.
Okay.
This could be something as, nothing is simple, but it could be looking at something like WellCare or United, asking them, to help with the management of that, to building our own health plan
Okay.
ourselves. And so,
I was looking for.
Yeah,
That's what I
okay.
was assuming, but I didn't know exactly what
Yeah,
that.
we quickly realized we did not have the infrastructure to do that.
Okay, thank you.
So as I started to look at what the goal was from an operating margin standpoint, and Bill and I worked together on this, you've heard consistently that as a highly rated health system, the expectation is around a 2% operating margin. The rating agencies will come in. It does impact the cost of debt. And 2% from my standpoint as a public hospital is a good margin. It's not too high. It's not, you do want to be able to spin off a little bit. That's really telling us that for every dollar we bring in, we're saving 2 cents. But we all know that there is a pretty large project that's going to be coming online in '24. So what I wanted to make sure that we did is we anticipated those operating expenses that would be hitting us from the PEC as well as the Southwest Medical Home. And we were not putting ourselves and overburdening the '24 budget with those expenses. So we have tried to hold that so that we don't just automatically go down to a 2% this year. We've got to plan for the future. So as I start to go through some of our other assumptions, and as we start to finalize the budget over the next week, just keep in mind that that was the goal. And we are trying not just to plan and deal with issues that we have in '23, but also plan and prepare ourselves for fiscal year '24.
But you're not projecting a 2% margin even in '22, are you, based on the budgets we saw yesterday?
No, we're not. Well,
We're going to have to recover, right?
no, we're well above the 2%.
Projected for this fiscal year?
Yes,
Okay,
yes.
including Acclaimed?
Yes, that, all of this is a consolidated number.
Okay.
Yes, sir. So I'm going to go through these fairly quickly unless you guys have questions. In volumes, there's no major change. In some of these, it does look like there's quite a bit of an increase, but we're really trending more heavily the last quarter or 4 months.
And this is not a political statement by any stretch. Are we anticipating higher birth admissions? Higher birth admissions over prior years?
No, we're really kind of holding those flat right now, and I'm really not sure what the capacity number is specifically, but that unit is fairly full most days.
Concerned about that?
Am I concerned about?
I'm concerned about
Oh,
that.
okay.
Because I do think volumes are going to go up.
So from an inpatient volume, this is kind of a new graph that you guys haven't seen, so let me take a minute and kind of show you what I'm building up here. This is almost a representation of the entire heads and beds, right? We are looking at admissions from behavioral health in the purple line, our OBS cases on the blue line, and of course our normal med-surg admissions with the red line. And you can see that overall those admissions are relatively constant, but we are going to be focusing on documentation, and we may see some of those OBS patients be more appropriately coded as inpatient. But overall, it's just about a 1% increase. Inpatient and outpatient surgeries, we're showing about a 4% increase.
Can I back you up on admissions for a second?
Yes.
So to me, this graphic makes more sense if it's shown as a function of capacity. I mean, if I'm looking at this and I'm seeing basically flat admissions, I don't think that tells the whole story if we're above capacity in some of the areas that we're measuring, because obviously it's going to be flat because that's all we got. So my question is, as we get closer to the budget being approved, if we have expectations on flat admissions, let's make sure we have contrasted that against capacity. Because if we don't have a capacity, then that line really doesn't mean a whole lot.
We have bumped this up against our licensed beds and feel comfortable with the 1% increase. We look at behavioral health differently than we look at the med-surg beds because that's a kind of a different licensure.
Right.
But this is just the overall volumes. But Trent, when we get into the 5-year look and beyond, we did have to limit volume growth in demand just based on the sheer number of beds that we have here. So if you remember some of the bond discussions, we are very careful in looking to make sure that we're within those licensure requirements.
It's just a critical feature of the strategic part of the bond plan.
Is.
Because to the extent that we can't necessarily statistically show increases in demand at JPS, some people see that as, well, you know, we're serving all that we need to be serving. Well, we're not. We're not even close. The key issue becomes capacity relative to that demand. So if we could contrast that as this develops, I think that might be useful to us. We're talking to people.
I think that's an excellent point, and I brought that up as to what our challenges are going to be, that we're going to have increased demand with really no growth in facilities at all until our new tower comes up. You know, we're really over licensed bed because COVID allows us to do that. That will go down, and so we could not show increase.
And each month I do, you know, part of the changes that we made a few months ago was to look at the capacity from the inpatient. And we're always hovering in the high 70s, low 80s, depending on the month. But, you know, even the rating agencies and other standards will tell you once you reach about 70%, you're having throughput issues and just bed turnover is very difficult.
Makes sense.
We are at capacity. We are hovering right at capacity in the mid-90s, I would say, for behavioral health at any given time, which is how we utilize those external partners that we have here in the community for those outside medical service. Are we ready to move on to surgeries? I didn't mean to move too quickly. So for surgeries, most of our increase there is going to be in the outpatient arena. We did look yesterday and kind of saw that trend for the last few months. We've had sustained higher outpatient volume, so we're just really projecting that throughout the rest of the year with a modest increase in the inpatient. I've combined some things here in emergency and urgent care. You can see the bottom line there, behavioral health, the PEC. We also have our urgent care, which is on the first floor in this building, as well as the larger emergency center. Modest increases there, about 2%. Small increases across the board. Our outpatient clinic volumes, you can see here too, part of this graph shows you FY19, which is what we have termed pre-COVID volume, and we're exceeding that this year. It's taken a few years of recovery. You can see the largest growth is going to be in the specialty clinic volume. We do have a slight increase in the primary care visits, and behavioral is keeping pretty steady. Yes.
Help me reconcile the fact that the data points on the top line don't reflect the axis values to the left. I mean, I've got 185,684 sitting at the 360,000 index on the axis.
That is true, Trent. The axis should be on a 200,000 visit.
Oh, okay. That makes a big difference.
Yeah, if I apologize for that. I'm not sure quite what happened. We've been cutting and pasting some of these slides, so we will fix that for the 11th.
Thank you.
So from an Acclaimed provider volume, if you look at that, we are increasing about 8.6%. Again, the largest increase there is going to be in the visit, the clinic and specialty E&M code visits. And then you'll see that the medicine, surgery, and other categories there at the bottom of the graph are fairly constant as we move forward, but it's the E&M code that's driving that 8.6% increase, and that's also complementary to what we're seeing in our clinic visits on the medical center side, although there's a lot more going on in here than just the clinic visits. Ad valorem tax revenue, it is always a nail biter. We have been told several times to expect about an 8% increase this year. When the certified tax rolls came out last week, it was a 12.6% increase. And that is a constant tax rate from last year. Our supplemental funding, Dr. Duncan talked a little bit about this. It's really not going to change in total too much. If you remember, our Medicaid supplemental funding, those first two bullets are actually recorded as kind of other operating revenue. And then CHIRP and TIPS at the bottom of the page is actually paid per claim, and it's reported in net patient revenue. And that represents a CHIRP for the medical center and TIPS for a claim. Our UC pool is going to increase quite a bit, but our DISH concessions through the public health emergencies are going to go away. So those two offset each other. And then we've also lost our DSRIP program, even though we did receive some final payments from 21 during this fiscal year. That's what's causing that decrease in that area. And then we always look for improvements. On our rev cycle, we've identified $7.5 million through different programs. The largest one is some of the automation on the medical center that you guys approved through a contract. And the Acclaimed is doing a similar computer-assisted coding project this next year. And then with some other implementations, we were able to recognize about $900,000 of efficiencies as well. Supply chain, we've got some collaboration going on with the OR and nursing for some high variability surgical cases. A lot of these are implants in orthopedics, in cardiac, as well as in podiatry. We've also got a target of $1.5 million to maximize some of our new GPO volume discounts and identification of some additional suppliers. We're also really focused around cardiac surgery nursing and then just general purchase services with our category managers. They'll be looking for savings. So some additional assumptions that weren't on some of these other pages. Acuity and payer mix remain relatively constant is our assumption. FTEs per APD will remain constant as well. We are projecting about a 5% supply and pharmacy inflation number. Some of those have evened off, but pre-COVID, I would have told you we would have budgeted somewhere between 2 and 3%. It doesn't sound like a lot, but a percentage ends up being a really large dollar amount for us. And the capital budget, we are right around $40 million, and that does include $10 million that's earmarked for the master facility projects. Any questions or?
Why are we mixing the capital budget with the bond program budget?
because we are only issuing 800 million. So it's part of the JPS Future Fund that we're adding 10 million a year to historically. We have earmarked that 10 million every year for the JPS Future Fund that will help us reserve those operating dollars and create a cash flow that will help.
So the $10 million is not necessarily dollars that we are earmarking for the bond program. It's $10 million we're adding to the future fund. Right?
Yes.
Okay.
It's going into the JPS Future Fund, which is for the bond projects.
And I'm hypersensitive to this, and y'all are all probably sick of hearing it, but I'm going to keep saying it. If we can't consistently, constantly, completely separate the bond fund activities from JPS capital dollars, we're going to end up looking very bad when the overall capital costs for the bond program are exceeding what they originally thought they would be. And here we have now mixed in the JPS capital projects. It just is not good optics. So we, in my opinion, we have to keep these things separate, because if we don't, it's going to come back on us. It's going to be like, hey, you know what? The bond program cost more than we thought it was going to be, but JPS, you've got another $150 million in there that may be attributed to the bond campaign, which is not. It's the capital cost for the hospital that we have to keep doing every year, irrespective of what happens with the bond campaign. So especially given the political changes and the likelihoods of scrutiny in the future, let's please keep those absolutely segregated.
Well, I will modify the final presentation to reflect the JPS Future Fund instead of.
Thank you. Any other questions? All right. Yeah. That's all for the open session, correct? Okay, all right. So why don't we close the open session at 2:15, and then we will go into closed session at 2:20, okay? All right.
decision that she needed to spend more time with family, it made it more difficult to really counter when somebody wants to spend time with family. With that said, we will, I think there's been about 6 positions that we've either decided not to fill or that have been brought down in our attempts to slim the amount of leaders that we have and concentrate on the work that we need to do. But we are at risk for a number of our executives, and so I do have some fears, I'll be honest with you. My good leaders such as Jill, such as Joy, I did, give a retention bonus last year in order to keep them at least through the year, but we're going to struggle in being able to keep executives. I'm just...
Because I thought about a Lauren Poe, is that she's been an asset to to the hospital, but she has brought us to the table to help you, Dr. Duncan, that you look at a consultant would have brought.
Yeah.
She's done that work where we normally would have paid some
Paid somebody to
consultant.
do it, yeah. Mhm.
Yeah, so if we don't get presentations that look this nice because of Lauren left us.
Yeah.
Okay, well, thanks, everybody.